Go ahead.
Okay, I'm provided with sagittal CT scan image from the neck region, cervical vertebrae, and another is a focused image of mediastinum contrast enhanced study. In the sagittal CT scan image bone window setting, I can appreciate that there is irregularity and a high density within the anterior wall of the trachea, tracheal lumen, and on the cross-sectional imaging of the axial imaging, there is again this circumferential hyper-enhancing thickening within the intraluminal thickening within the wall of the trachea. And this is causing irregularity of the lumen of the trachea. The major vessels of the mediastinum, they appear normal. No evidence of any soft tissue attenuation mass in the trachea. No lymphadenopathy in the given image. And these findings, they are showing some, this could be these soft tissue nodules that are lining circumferentially the tracheal lumen could be the papillomas, tracheal papillomas, or secondly, maybe malignant like tracheal squamous cell carcinomas. However, as these are very much enhancing and they are polypoidal in shape and projecting into the lumen, so I would keep both of these in my differential.
Okay. One thing, sorry, just let me direct you. So these are denser than the vessel itself. So these are basically calcification, and I'm not even sure whether it was a contrast examination or not. So these are basically calcification, which I'm trying to tell you. And so any other differential like?
So tracheomalacic changes, irregularity in the cartilage of the trachea. So these could be the tracheomalacic changes.
Okay, and
because there's quite disruption.
So basically these are calcification. There's one important point which was missed is basically relative sparing of the posterior wall.
Posterior ring, because that's the muscular wall. That's a muscle there, so it's sparing it.
So the cartilage is only U-shaped, right? So it is what cartilaginous part is.
Medial and lateral wall is involved.
Yes, right? And it's calcification, and it's involving throughout the trachea. So can you now definition?
Yes, sir. I'm unable to recall, but there is a cartilaginous
tracheobronchiopathica and osteochondroplastica, right?
Yes.
TPO, so TPO you can say. Okay.
Yes.
So this is what it is basically. Cartilaginous lesion with calcification, sparing the posterior. So there are two kinds of lesion with this, which involve the airway. I'll show you the differential. But these are 4 cases with 4 differential. Can you come up with what this one A could be?
Sir, this is.
So there, I'll tell you the finding and you get the diagnosis. So again, relative sparing of the posterior wall, diffuse involvement of the anterior and lateral walls, diffuse involvement, diffuse thickening without any calcification.
Yes, sir. So tracheal malignancy, either benign or
no, malignancy should involve the posterior wall as well, right? So usually this is a polychondritis, relapsing polychondritis, and C case you already know, which I've already shown you. This is tracheobronchiopathica osteochondroplastica, and the middle case, it's again diffuse involvement anteriorly as well as posteriorly without any significant narrowing of the lumen or any mucosal lesion. The mucosa is very smooth. And if I say that this patient also has sinus disease and renal failure as well, then it would become vaginous granulomatosis. Exactly. So similar appearance like diffuse involvement, anterior and posterior both, and bronchi involvement as well. And some high definition calcification, but the calcification is more like amorphous calcification and diffuse, not like nodular chunks like this one. So this would be the 4th one, which is amyloidosis. So these are the common causes, or common 4 causes of tracheobronchial involvement. So any cartilaginous disease usually spares posteriorly, like relapsing or tracheobronchopathica, osteochondroplastica. They spare the posterior wall. The more inflammatory diseases or depositional diseases involve both anterior and posterior wall, and these could be their differential. Malignancy usually have more irregular contour, and but obviously sometimes if there's diffuse involvement or even a focal polypoidal involvement, it's hard to exclude. But these are the 4 usual causes. Okay, so these are the lung cases, and I'll move on to the other specialties if there is still time. So I'll just briefly describe the approach to the diffuse lung disease. So there are 6 different patterns of the lung involvement, whether it is airway, interstitial, nodular, mosaic, or cystic lung disease. I have tried to show all the spectrum in airspace, interstitial, every pattern. I've tried to show one case. Then the distribution and the ancillary findings and acute and chronic involvement. So I'll just skip that. These are acute airspace disease and nodular pattern. I've already told you that could be acute, chronic, or perilymphatic and centrilobular pattern. Okay.
So bone density appears normal. All the joint spaces are preserved. There is a slight sclerosis and increased density on the bilateral humeral heads, likely due to avascular necrosis.
Okay, yeah.
Cardiac size is mildly enlarged, and the visualized vertebral bodies are slightly depressed centrally. So it might be the case of sickle cell disease with the bilateral humeral avascular necrosis.
Excellent, excellent. So this is a sickle cell disease, and the lung findings, basically there are some coarsening of the interstitial marking, and this is acute chest syndrome in the, so these patients can present with acute bone crisis or acute chest syndrome, presenting with acute exacerbation of the vaso-occlusive diseases anywhere in the body, basically mostly in the bones or in the chest. So this is the same case. What additional findings do you see here?
So they are fish-shaped vertebra with decreased bone density.
Yeah, so these were, you have picked up well on the chest radiograph. So these are just basically fish cord vertebra or whatever you call it. Do you see anything in these images?
Sir, there is consolidation in the left lung field area of consolidation.
Yeah, some airspace disease. As I showed you, the X-ray. The X-ray did had like acute chest syndrome, so interstitial prominence, airspace densities were there. Do you see anything else other than the lungs?
Paravertebral soft tissue, bilateral paravertebral soft tissue.
Bilateral soft tissue. What could that be in this case?
Sir, extramedullary hematopoiesis.
Excellent, extramedullary hematopoiesis. And this is the left upper quadrant. Do you see anything here? Anything going on? What could this be? What could this be? This is the stomach anteriorly, right? What is the posterior to the stomach? Just linear. Sorry?
Calcification.
Yeah, calcification. So this is autosplenectomy, basically what we call. So spleen is basically all gone, necrosed and shrunk and calcified. So autosplenectomy is what. So you have picked up all findings basically. So autosplenectomy, extramedullary hematopoiesis, and the bone changes in the sickle cell disease. Good.
Thank you, sir.
These are just increased sclerosis in the humeral head, especially basically all the bones are very increased in density, and subchondral cystic changes in the humeral head. So again, avascular necrosis, but this is 70-year-old. The other patient was young, right? So similar increased bone density and avascular necrosis and diffuse replacement of the bone marrow with splenomegaly, right? In a 70-year-old. So this becomes a diagnosis of myelofibrosis. Basically, in other hemolytic anemias, usually the spleen, like sickle cell disease, spleen is shrunk, but here spleen is enlarged, and this is all marrow infiltrative disorder with avascular necrosis and splenomegaly and this is the same case with myelofibrosis, but these are actually extramedullary hematopoiesis in the epidural fat. So epidural fat does have like a stem cell remnant, and not only the paravertebral masses where there are remnant and become a source of extramedullary hematopoiesis, epidural masses can, if they are similar kind of epidural masses, lipomatosis is one of the differential. But in those cases where there can be a cause like myelofibrosis or sickle cell, you can have epidural extramedullary hematopoiesis as well. Just a dedicated MR of the foot. The abnormality is basically at the Lisfranc joint. So the ligament is torn here. This ligament supports the Lisfranc or joint between the base of the metatarsals and the cuneiform. So it's an unusual modality to see this finding. So that's why I showed you this. But in most of the MSK cases, if you are not given the plain X-ray, you should ask for it, because MSK, it's very hard to come up with any diagnosis in the absence of the plain radiograph. So this is basically Lisfranc fracture dislocation. And Lisfranc can be of three types. You all know probably that: convergent, partial incompatibility, and divergent type. So depending on how the bones are being fractured and displaced. So I'll skip for the other. Hand X-ray, the right one is more or less normal. The left one, if you see, you don't see the thumb. Basically, the thumb is fingerized. This is called fingerized thumb or triphalangeal thumb. So you can see that the thumb has three. So this is a congenital disorder. It looks like all 5 fingers without thumb. Is basically the thumb is basically triphalangeal, and you can see the radial styloid is abnormal as well compared to the other side. So this is basically Holt-Oram syndrome. So in the chest radiograph, if you are shown cardiomegaly with findings which suggest ASD, then this becomes Holt-Oram syndrome. There are many syndromes associated with triphalangeal thumb, which are very rare. This is another X-ray hand, and here if you see, this is a very subtle finding, but it should be shown. Though I've tried to zoom it as well. So you can see a fracture at the base of the fifth, at the base of proximal phalanx of the thumb. So this is basically, if it is an acute setting, it is gamekeeper's thumb or chronic skiers. And the reason I showed you this because of one other entity which is related to both these, which is a Stanner lesion. So Stanner lesion is basically what happens is that there is I'll show you the MR here. So this is the normal, this is the adductor aponeurosis, and deep to this is the ulnar collateral ligament usually lies. If there is an avulsion fracture of the ulnar collateral ligament, so if it is not displaced, then usually it is allowed to heal. But if it is displaced and the aponeurosis comes here and becomes yo-yo in a string sign, like this avulsed ulnar collateral ligament becomes the ball of the yo-yo, then this becomes like entrapped lesion or displaced lesion. So this becomes a surgical candidate. And the surgery should not be delayed long, because otherwise it fibrosed and then reattaching it. So it's a very disabling. It's a small. And this is just a case of basically multiple lucent lesion with ground glass densities and expansion in a 40-year-old. So this is basically a fibrous dysplasia. The reason I showed you this because of its association. So in the There are this is polyostotic fibrous dysplasia. You can see there are several other lesions in the left femur as well, and there are muscular intramuscular myxomas as well. So multiple polyostotic fibrous dysplasia with intramuscular myxomas becomes Meza-Brod syndrome. So this is Meza-Brod syndrome. I saw interesting one. We saw it in the CT. The patient presented with some swelling in the left mid thigh, and you saw slight diffuse stranding in the subcutaneous fat here compared to the right side, and there was no enhancing mass of soft tissue. And the referring physician asked for MR as well to rule out any hidden lesion in the muscles or somewhere else. So we did. So again, diffuse stranding in the subcutaneous fat only, without any mass effect or like solid enhancement. So this is a case of you can see this is a similar pathology somewhere else. So these are basically fat necrosis. So fat necrosis not only happens in the breast, they can happen anywhere where there is a fat, basically. So this is a epicardial fat necrosis, which can actually confuse clinician as MI, and a patient may end up going for an angiography or other investigation unless you find out this thing on the CT. So similar findings in the bowel wall, we call it epiploic appendicitis. Fat necrosis can happen anywhere and can happen in the lipomas or due to more common in obesity. That's another case. That's a panoramic ultrasound, and you can see a cystic lesion within the ultrasound, and you can see some echogenic foci within it, floating within it, and they have some artifacts, which is the main purpose of the discussion in this case. So if somebody sent you to biopsy this one, you should not biopsy this one. This is a typical colloid cyst, and the reason being that it has the artifact, which is basically the comet tail artifact. So there are two types of similar artifacts. One is comet tail artifact, the other one is ring down artifact. They both comes in the category of reverberation artifacts. And ring down previously is thought to be a variant of comet tail, but they are completely different pathology, etiology, and cause. So the ring down artifact is happens because of the gas shadowing, which is dirty shadowing, echogenic line, while the comet tail has several areas of reverberation behind it. So I'll just briefly skip. You can read about this. So this is the comet tail artifact, ring down, multiple bright and black, while the ring down is more for continuous with the dirty. Okay, so this is another case here. The surgeon, the respirologist was trying to push us to biopsy it. It has been followed up, and there is a ground glass density here, which has some slightly increased in previous, and they asked for biopsy. So this is again a no biopsy lesion. Basically, it's a pure ground glass density, and if you see here protuberance, there's a focal protrusion of the osteophyte. So we call it focal interstitial fibrosis, which is usually adjacent to the osteophytic protrusions. Basically, because of the indentation, the lung undergoes some fibrosis there, and that's the cause of it. So again, no biopsy lesion. If you see the typical finding, it should not be biopsy. This is a case where you are trying to do a biopsy. Now there is a nodule in the lung which we are trying to biopsy. Now you've done biopsy without any complication in the chest at the time, but then patient immediately became drowsy and less responsive, and also complaining of chest pain. So basically, this is more related to the post-procedure related complication. So we did CT head, and you see here the gas bubbles. Here you can see the gas bubble in the aorta. You can see even in the coronary arteries. So basically, what happened in this biopsy, which is one of the side effects, and you must be aware if you are doing biopsies that whenever you do, nowadays we usually do core biopsies. Previously, back in the day, we used to do only fine needle aspiration. Now we all do 20 kH coaxial biopsies of so pulmonary veins usually have negative or lower pressure than atmospheric pressure. So if the coaxial needle is being left open, and if you happen to traverse through or you're close to the pulmonary vein, then what happens is the gas can, atmosphere or air can go into the pulmonary vein, and then it goes into the left atrium, left ventricle, and into the aorta, and we guess where it will end up. It can end up in the brain, coronary arteries, any vessel basically, in the lower limb as well, but in the lying down position, it can even go to the carotid. So this is something to be aware, and as soon as you suspect that there is air embolism, you should try to put the head down, just because you don't want this gas to end up in the brain basically. So Trendelenburg position, probably legs up, so that if it has happened, the air should go into the leg rather than in the vital structures. So this was about and if you do see it, you should start on hyperbaric oxygen and other treatments.